hypertension, for obesity, and overweight. All right, so let's look at what happens with obesity. First thing you have to think about from a cardiovascular standpoint is total blood volume. That means circulating volume, plasma volume, both those increase dramatically. Remember, for every kilogram of adipose tissue, you add 3,000 meters of blood vessel. 3,000 meters of blood vessel. Along with that, because you have an increase in circulating volume, total blood volume, you have an increase in pulmonary blood volume. You also have an increase in cardiac output because of that to compensate for the increase in blood vessels. And along with that comes an increase in stroke volume. Now, remember that we talked about, and we noted an increase in cardiac output. But when you get to a certain point with obesity, the body, the heart, because of the strain of obesity, is no longer able to compensate with an increase in cardiac output from the standpoint of increase in total blood volume, and that's when you get into heart failures. You have pulmonary hypertension. What you usually see with that is exertional dyspnea, fatigue, syncope. You have right ventricular dysfunction and strain. You have right ventricular hypertrophy. What you'll see on an EKG are tall precordial R waves. And the other thing is a definitive diagnosis of right ventricular hypertrophy would be tricuspid regurg. So these are things for you to think about when you also look at a patient and do your complete workup. Mild to moderate pulmonary hypertension warrants the avoidance of nitrous and any other type of medications or anesthetic agents that we may use that may cause an increase in cardiac output just because, cause an increase in cardiac strain. Any kind of vasoconstrictors. Inhalation agents are very, very beneficial because of bronchodilation and the ability to decrease hypoxic pulmonary vasoconstriction, which plays